Imagine a patient eats a grapefruit for breakfast, takes their normal everyday cholesterol medication, and then accidentally triggers this massive, life-threatening overdose.
Yeah, which sounds impossible, but it happened.
Right. Why does a literal piece of citrus fruit basically turn into a toxic chemical weapon in the body? Well, welcome to the deep dive.
We are so glad you're here.
For you listening right now, we know exactly what your week looks like.
Yeah?
And, let's just acknowledge the absolute gauntlet you are running right now.
It's intense.
Monday is your PN fundamentals exam. Tuesday and Wednesday, you're in clinicals. And then Thursday is the massive pharmacology exam.
And looking ahead, the pressure really doesn't let up, you know? Next week kicks off with NCCVC 102 on Monday,
Ugh, yeah.
followed immediately by HSRI retest day on Tuesday, Wednesday, and Thursday. Plus, you have to keep an eye on your inbox for that ATI wrap-up session and that pre-work email they requested. It's just an incredibly dense schedule.
It is. So today's mission is custom tailored to be your ultimate high-yield study session. We took that massive stack of pharmacology notes you shared with us and really just distilled it down.
Exactly. We're focusing strictly on the critical safety alerts, the nursing assessments, and patient education points. Basically, the exact concepts showing up on Thursday's exam.
But we're not just going to read a list of facts, right?
No, because memorizing a list of generic names might get you through a pop quiz, but to pass a massive pharmacology exam, you really must understand the underlying physiological mechanism.
You have to know the why.
Right. You need to know the specific cellular reason you must take an action or, assess a baseline before handing a pill to a patient. When you grasp the why behind the drug, the exam questions just cannot trick you.
I love that. So let's start with the cardiovascular system, the pipes and the pump.
The plumbing.
Exactly. The medications that manage blood flow and pressure have these highly specific exam-relevant side effects. So let's look at ACE inhibitors first. Those are the drugs ending in -phyrl, like lisinopril and enalapril.
Right, which manage hypertension by basically interrupting the pathway that constricts blood vessels.
Right, but there's a major non-intuitive side effect in your notes, a dry, hacking cough. Wait, why does a blood pressure medication cause a cough? It sounds like the patient is suddenly getting sick, like a respiratory infection.
Yeah, and that cough is a classic exam trap. The patient is not developing an infection at all.
Really?
Yeah, the specific enzyme these harpal drugs inhibit to lower blood pressure, the angiotensin-converting enzyme, it actually has a second job.
Okay.
It's normally responsible for breaking down a chemical called bradykinin in the lungs. So when the medication blocks the enzyme, the bradykinin just isn't broken down.
So it just builds up.
It accumulates right in the respiratory tract and acts as a severe irritant.
Wow. Okay, so the cough is a direct mechanical result of that bradykinin buildup, not a virus.
Right.
That completely dictates your patient education then. You have to explicitly warn the patient that a dry, hacking cough is an expected side effect.
Yes, absolutely. Because if you skip that education, they're going to panic, assume the heart medication is giving them bronchitis or something, and just stop taking it.
Which is terrible. I also see a massive safety alert here for ACE inhibitors regarding pregnancy.
Oh, yes. They are heavily contraindicated. ACE inhibitors carry a black box warning because altering that specific blood pressure pathway during fetal development causes severe renal damage and cardiovascular deformities in the fetus.
Wow.
Yeah, it's an absolute red flag assessment for any patient of childbearing age.
Got it. Which actually brings us back to that grapefruit scenario from the intro. We're talking about statins now, right? Like atorvastatin, rosuvastatin.
Yep, the cholesterol meds.
Your notes highlight a major interaction between statins and grapefruit juice. Like, I understand they shouldn't be mixed, but mechanically, why is a breakfast drink causing a systemic overdose?
So consider the liver's disposal system. The liver uses a very specific family of enzymes, the cytochrome P450 pathway, to metabolize and clear statins from the bloodstream.
Okay, the P450 pathway.
Right. Well, grapefruit juice contains compounds that completely bind up and paralyze those specific enzymes.
Oh, wow. So the liver's disposal system just hits a roadblock.
Exactly. The patient takes their normal daily dose of the statin, but yesterday's dose hasn't been cleared yet, so the medication just accumulates exponentially in the blood.
They are literally stacking doses without even realizing it.
Yes.
So what does that systemic buildup actually do to the body?
It leads directly to the highest yield nursing assessment for statins, which is myalgia. muscle pain.
Just for the buildup.
Yeah, but it's not just a mild ache. It's the actual physical breakdown of muscle tissue, which can progress to this dangerous condition called
That
rhabdomyolysis.
sounds intense.
It feels like severe flu-like body aches, and this myalgia is actually the primary reason patients become non-compliant and stop taking the drug.
That makes sense. And as a nurse, you must also educate the patient that being on a statin doesn't give them, a free pass to ignore dietary modifications.
Definitely not. Managing cholesterol is still a dual approach of medication and lifestyle.
Okay, let's look closer at the blood itself. We have antiplatelets and anticoagulants. On a multiple choice test, they can sound identical because they both prevent clots.
Right.
Yeah.
But a nursing student really needs the mechanistic difference.
Hmm.
So if platelets are like the twigs and leaves floating down a river that jam together to form a crude dam when there's a leak, antiplatelets like aspirin and clopidogrel, they stop those twigs from sticking together in the first place.
Right, they prevent that initial platelet plug.
Okay, so what is the actual difference between that and an anticoagulant?
Well, anticoagulants target the next step. To make that twig dam permanent, the body initiates the clotting cascade to pour a concrete-like substance, the fibrin mesh, over the twigs.
Oh, yeah.
Anticoagulants actually alter that clotting cascade. They essentially stop the body from pouring the concrete.
So antiplatelets stop the twigs, and anticoagulating stop the cement.
Exactly.
But because both classes inherently sabotage the body's ability to stop a leak, the bleeding risks have to be paramount, right?
Oh, absolutely. And exams won't just ask about a paper cut that won't stop bleeding. They're testing on the subtle, insidious signs of internal or systemic bleeding.
Like what? What should you look for?
You need to assess for manifestations like bloody tears, bleeding from the ears, or petechiae.
Petechiae.
Yeah, they present as tiny pinpoint red or purple bruises right under the skin, which indicates capillary leakage.
Wow, okay.
And the patient education points here are rigorous. Patients must use an electric razor, never a manual blade that can nick the skin.
Because even a small cut is a big deal.
Right. Fall precautions are totally non-negotiable because a simple bruise can just become a massive hematoma.
Yeah.
And if they are scheduled for any invasive procedure or surgery, you must document their exact last dose.
They can't just stop taking it before surgery.
Never abruptly stop without medical direction. The rebound risk of a fatal clot often outweighs the surgical bleeding risk.
Okay, so we just talked about stopping the blood from clotting, but what happens when we need to manufacture more blood? The notes mention this drug, epoetin alpha.
Yes, epoetin alpha is a synthetic version of erythropoietin, which is a hormone normally produced by the kidneys.
Okay.
It travels to the bone marrow and stimulates the progenitor cells to manufacture large numbers of red blood cells. It basically forces the factory into overdrive.
But the exam rules for administering this are incredibly strict, right? Like you have to check hemoglobin levels before every single administration.
Yes, every single time.
And the cutoffs are rigid. Do not give epoetin alpha if hemoglobin is greater than 10 grams per deciliter for cancer patients or greater than 11 grams per deciliter for renal or dialysis patients.
Yeah.
Why those specific numbers?
It comes down to blood viscosity.
Yeah.
Red blood cells are solid matter. If you push the hemoglobin higher than those targets, the blood literally becomes too thick.
Like sludge.
Exactly. It's the difference between the heart trying to pump water versus trying to pump thick mud through the vascular system.
Oh, wow. That sounds dangerous.
It is. The risk of severe cardiovascular events, myocardial infarction, stroke, heart failure, just skyrockets because that sludgy blood is highly prone to thrombosis.
So the nurse really has to act as the gatekeeper here. Check the hemoglobin, verify it's under the threshold, and only then administer the drug.
Precisely. And two other vital exam points on epoetin alpha. First, the therapeutic effects are not immediate. It takes 2 to 6 weeks for the bone marrow to actually mature those new cells.
Okay, so it's a slow build.
Right. Furthermore, because the body is suddenly churning out millions of new red blood cells, it rapidly depletes its raw materials.
Oh, like iron.
Yes. Patients will almost certainly require concurrent iron supplements. And you have to check their plasma ferritin levels to ensure their iron stores can even support the new production.
That makes total sense. So the blood pumped by the heart delivers oxygen directly to the most sensitive organ in the body, right? The brain.
The control center.
Exactly.
Yeah.
That brings us to the medications that alter the body's electrical grid, the nervous system. And managing this grid requires serious caution because over-medicating can basically suppress the central nervous system until the vital functions just shut down completely.
It's a delicate balance.
Let's compare opioids and benzodiazepines. I mean, it's like they're both a dimmer switch for the body, right? They both slow the system down, but they act on entirely different receptors. Benzos amplify the body's natural braking system, GABA, while opioids bind to pain receptors to block signaling.
Right. But despite the different pathways, the ultimate danger for both classes is identical, and that's respiratory depression. The brain just simply forgets to tell the lungs to breathe.
Terrifying. So how does a nurse prioritize their assessments when the switch gets turned too low?
Well, the nursing assessments prioritize different immediate risks based on the drug. With benzodiazepines, the enhancement of that GABA braking system causes severe ataxia and the sedation.
Okay.
So your priority is assessing their level of consciousness and implementing strict fall precautions. You also absolutely must screen for suicidal ideations and any history of substance abuse.
And there's a hard rule about withdrawal with benzos, right?
Yes, you never abruptly discontinue a benzodiazepine. The brain has adapted to the constant presence of that braking system.
So if you take the brakes off suddenly,
The electrical grid overloads, triggering severe withdrawal symptoms, including life-threatening seizures.
wow. And what if there's an overdose?
If you encounter a benzo overdose, the specific antagonist, the antidote, is flumazenil.
Okay, flumazenil for benzos. Got it. Now, for opioids, assessing respirations and blood pressure remains the top priority. But opioids also bind to receptors in the gastrointestinal tract, right? Basically paralyzing peristalsis.
Exactly. Assessing bowel habits is critical. Opioids cause severe, obstinate constipation, so patient education has to emphasize increasing dietary fiber and fluid intake.
And the antidote for an opioid overdose is Narcan, or Naloxone. But there is a massive exam trap regarding combination opioids, right? Like a medication mixing hydrocodone with acetaminophen.
Oh, this pitfall appears on almost every pharmacology exam.
Really?
Yes. When administering a combination drug, the nurse must meticulously calculate the total daily dosage of the acetaminophen component.
Because of the liver.
Exactly. The opioid will slow their breathing, but acetaminophen toxicity silently and permanently destroys the liver.
So they might not even realize it's happening.
Right. Patients often hit the fatal daily maximum limit of acetaminophen long before the opioid component even reaches toxic levels. You just have to monitor the 4, 6, or 8-hour dosing intervals mathematically.
That is such a good point to remember for Thursday. Okay, let's shift to antipsychotic medications. Patients frequently express a desire to stop these medications because the side effects make them feel disconnected or just not like themselves.
It's very common.
But the major high-yield red flag for your exam here is tardive dyskinesia, or TD. What is going on there?
So tardive dyskinesia is a direct result of long-term dopamine receptor blockade in the brain. The brain essentially tries to compensate by making the remaining receptors hypersensitive.
And what does that look like in the patient?
It manifests as involuntary, repetitive muscle movements, often in the face, jaw, or extremities, like lip smacking or grimacing.
Oh, okay.
The critical exam point here is its irreversibility. Once tardive dyskinesia progresses, it can become a permanent neurological condition even if the drug is stopped.
Permanent. So the nursing action has to be immediate.
Inform the provider at the very first sign of those involuntary movements. Do not wait for the next shift.
And there is a specific trap associated with TD in the notes. Do not administer benstrapan.
Right.
Benstrapan is an anticholinergic drug commonly used to manage other extrapyramidal side effects of antipsychotics, like acute dystonia. But for tardive dyskinesia, it actually exacerbates the condition.
Yes, mark that contraindication down for Thursday. It's a huge one.
Will do. So let's look at two other specific neurological drugs, topiramate and memantine.
Okay, topiramate is an anti-epileptic drug that suppresses excessive electrical firing in the brain. It's used for seizures and preventing migraines.
Right.
It carries a strict FDA teratogenic warning, though, for an increased risk of cleft palate if taken during pregnancy.
Good to know.
But the major safety alert involves the eyes. Topiramate can physically block the drainage channels of fluid in the eye, which rapidly increases intraocular pressure.
Oh, that sounds painful.
It is. Patients must be educated to immediately report any visual changes or eye pain, as this angle closure glaucoma can literally cause permanent blindness.
Okay, that is a massive safety alert. What about memantine? That's used for Alzheimer's, right?
Yes, for moderate to severe Alzheimer's disease. A key patient education point here is managing expectations. This drug does not cure Alzheimer's. It only slows the cognitive decline.
How does it actually work in the brain, though?
To understand how, we have to look at the calcium flood.
The calcium flood.
In an Alzheimer's brain, pathological changes cause a massive overrelease of glutamate, which is an excitatory neurotransmitter.
Okay.
That excess glutamate constantly bombards the NMDA receptors on the neurons. This forces the receptors open, allowing a toxic flood of calcium to just pour into the cell.
And that's bad.
Very bad. That calcium overload literally excites the neuron to death, a process called excitotoxicity.
Oh, wow. So where does melatonin come in?
Memantine acts as an NMDA receptor antagonist. It physically plugs that receptor pore, blocking the excessive glutamate from binding, stopping the calcium flood, and preventing further neuronal death.
So it basically just caps the receptor to stop the flood?
Ah.
That's a great visual. Let's talk about amantadine, because I noticed a really strange overlap in the notes here.
Oh, yeah.
Amantadine is an antiviral medication used for influenza A, but it's also listed as a primary treatment for Parkinson's disease. Wait, how does an antiviral for the flu alleviate a neurodegenerative movement disorder?
It's pretty fascinating. The drug just happens to have two entirely separate mechanisms of action.
Really?
Yeah. For the flu, it blocks a specific viral protein, preventing the virus from uncoating and replicating inside the host cell. But in the central nervous system, amantadine crosses the blood-brain barrier and forces the neurons to release stored dopamine while simultaneously blocking its reuptake.
Oh, and since Parkinson's symptoms are driven by a severe deficit of dopamine.
Exactly. This artificial surge reduces tremors and improves physical mobility.
That's amazing. Now, the nursing assessments for amantadine are very specific. Renal function is critical. You have to check creatinine clearance because the drug is excreted entirely unchanged by the kidneys, meaning it requires dosage adjustments for any renal impairment.
Right.
You're also assessing for orthostatic hypotension and mental status changes, particularly like hallucinations in elderly patients. But the most visually distinct side effect is livido reticularis.
Yes. The blood vessels in the skin constrict, which traps deoxygenated blood near the surface.
And that creates that mottled, purplish, lace-like discoloration,
Yeah.
usually on the legs, right?
Yes, exactly.
Okay, so the brain orchestrates every muscle movement in the body, but it relies on specific electrolytes to carry that electrical signal, which transitions us perfectly to the final section of your notes. High-risk administration rules?
Because exams don't just test what a drug does, they test the specific physical protocols of how a nurse administers it.
Exactly. And we have to discuss potassium. I like to call potassium the diva of the medication cart because of how finicky its administration rules are.
That's a very accurate name for it. Potassium is essentially a highly calibrated trigger spring for the heart's electrical system. It maintains the resting potential of the cardiac cell membrane.
So even microscopic imbalances can cause lethal cardiac arrhythmias?
Yes. And because it's cleared by the kidneys, baseline renal function tests are absolutely mandatory before administration. But the administration rules contain the biggest exam traps here.
What's the most critical one?
The most critical safety alert in pharmacology. You never, under any circumstance, administer concentrated potassium via IV push.
Never.
Never. Normally, potassium sits at high concentrations inside the cardiac cells with very little in the bloodstream. If you push a concentrated syringe of potassium directly into a vein, you instantly reverse that gradient.
Oh, boy.
The cardiac cells cannot repolarize, and you will induce immediate cardiac arrest.
So it must always be heavily diluted.
Heavily diluted. You hang a mini bag of IV fluid with the potassium added, or you mix it completely into the primary IV bag, and it is given slowly over hours on an infusion pump.
Got it. Now, the oral form PO of potassium has its own administrative trap. It often comes as a dissolvable powder or an effervescent tablet meant to be mixed in water. But the heavy particles tend to sink and form this sludge at the bottom of the cup.
Right.
If the patient drinks the water and leaves the sludge, they didn't get their prescribed dose. So the nurse must physically agitate or stir the mixture vigorously right before handing it to the patient to ensure the powder is suspended and the full dose is actually swallowed.
That is a great practical tip.
Let's move to respiratory inhalers.
Oh.
The notes list albuterol and fluticasone. I want to ask why the sequence of administration is so rigidly tested here.
Well, this is pure anatomy and physiology. Albuterol is a short-acting beta-2 agonist. It relaxes the smooth muscle around the bronchioles, acting as a bronchodilator.
Right.
Fluticasone is a corticosteroid. It works at the tissue level to reduce underlying inflammation. During a respiratory exacerbation, the airways are physically constricted. The passages are literally swollen shut.
So if you administer the steroid first,
The medication just hits those constricted walls and stops. It cannot travel deep into the lungs to reach the inflamed tissue.
so you have to do it the other way around.
Exactly. You must administer the bronchodilator, the albuterol, first. That forces the airways to dilate and open up. You wait a few minutes, and then you administer the corticosteroid, the fluticasone, second.
Because the newly opened airways act as a clear highway, basically, allowing the steroid to travel deep into the lower respiratory tract where it can actually do its job.
Perfect analogy, yes.
Awesome. Two more specific drugs with strict administration handling: finasteride and sapropterin.
So finasteride is a 5-alpha reductase inhibitor used for benign prostatic hyperplasia, or BPH. It works by blocking the enzyme that converts testosterone into its more potent form, DHT.
Which is what fuels prostate growth, right?
Exactly. By
Yeah.
blocking DHT, the prostate physically shrinks. A key testing point here is the timeline. Because it alters cellular growth, therapeutic effects actually take 3 to 6 months to appear.
And finasteride is highly teratogenic because it alters those male hormones.
Very much so.
The handling precautions are severe. It is absolutely contraindicated for women. Pregnant caregivers or pregnant partners cannot even handle crushed or broken tablets, right?
Correct. The drug can be absorbed through the skin and cause severe abnormalities to a male fetus.
Wow. Okay. And then sapropterin.
Sapropterin is used to treat phenylketonuria, or PKU, by supplying a synthetic cofactor to help break down phenylalanine.
And what's the administration rule there?
The critical rule here is that the tablet must be taken with a meal. Food physically slows down gastric emptying. This keeps the medication in the digestive tract longer, increasing its absorption time and maximizing the amount of active drug that makes it into the bloodstream.
Right. With a meal. Finally, we must cover the anti-infectives, the antibiotics.
Yes.
So a quick hit here. The first action before hanging any antibiotic is to verify allergies, specifically to penicillin and cephalosporins, which have cross-reactivity.
Right, but you must distinguish between an adverse effect and a true allergy.
Because patients confuse those all the time.
Constantly. GI symptoms like nausea or diarrhea happen because the antibiotic is indiscriminately destroying the normal, healthy flora in the gut. That is an expected adverse effect.
But a true allergy.
A true IgE-mediated allergic reaction involves a massive histamine dump, causing hives, facial swelling, and airway constriction.
Okay, very different. And the ultimate patient education point for antibiotics: they must finish the entire prescribed course, even if they feel better on day 3.
Yes. If they stop early, they've only killed off the weakest bacteria. The strongest, most resilient bacteria survive, learn to recognize the drug's mechanism, and mutate.
Creating those scary antibiotic-resistant superbugs.
Exactly.
Well, you have absorbed an immense amount of high-yield pharmacology today. Keep your schedule in mind. PN Fundamentals on Monday, Clinicals Tuesday and Wednesday, and this monumental pharmacology exam on Thursday.
You are putting in the intense work required to succeed.
But before we let you go, we want to leave you with, a physiological puzzle to ponder as you review these notes before the exam.
Think about how these individual drug mechanisms interact in a single, complex patient. For example, imagine a patient taking epoetin alpha.
Right. As we discussed, this stimulates the bone marrow to manufacture red blood cells, which actively increases blood viscosity and carries a distinct risk of blood clots.
But now, imagine that same patient is concurrently prescribed an anticoagulant which targets the fibrin mesh in the clotting cascade to actively prevent the blood from coagulating.
The body is engaged in this massive physiological tug-of-war. The factory is pumping out sludge to thicken the blood, while a chemical agent is simultaneously trying to tear down the clotting cascade. What happens to the body's delicate balancing act?
How do your nursing assessments shift when monitoring that extreme push and pull? Which labs become your absolute, non-negotiable priority?
Understanding those deep, complex interactions is what takes you from simply passing a multiple-choice exam to being a truly exceptional nurse. Keep that puzzle in your mind. Good luck on Monday, excel in your clinicals, and crush that pharmacology exam on Thursday. We will get you on the next deep dive.